I'll give people a couple more minutes, and then we can get started.
Still changing.
Yeah, right, it seemed like it. And this one was kind of ending a little late, so I'll give people a few more minutes. And if not, we'll maybe tighten up and have a nice little intimate hangout. So maybe while we wait, I can hear a little bit about you guys and your interest in, sorry, but I mean, this is specifically about health, so health and the built environment. So I guess I'm just wondering what the particular interest is here so that I can kind of focus the conversation a little bit more. So do you want to start?
I'm working, I have the health background.
Okay. And where are you working?
I'm working for UNICEF.
Okay.
I'm embedded in the Office for the Coordination of Humanitarian Affairs.
Oh, great. And are you based here in New York City? Oh, wonderful. Okay, thanks. Welcome. Hi.
Hi, I'm a social work student at Boston College.
Oh, cool.
And my internship next year is going to be with the Department of Public Health and their division of global populations and infectious disease prevention.
Oh, wonderful. You're in the right place.
My background is in economics, though,
Okay.
so I'm like marrying like the two fields, and so I'm just scared of them.
All right, that sounds good. How about you?
I'm doing the IIHA, and I'm worked class for MSF for Stanford.
Oh, okay, wonderful. Great.
I'm Charlotte. I actually work for Archive for Sarah,
She's a villain. She's put together much of the presentation, so she's familiar with it. By much, I mean all. Welcome.
sorry.
Yeah, don't worry. We'll give it, 2 more minutes, and then we'll get started. So we were just going around the room and just giving a quick sentence about your interest in terms of why you came to this particular session. Yeah, no, it's you, yes.
My name is Nadine, and I work for MSF, Without Borders.
Yeah.
So,
So you're interested in the health side. That's wonderful. And then the newcomer. Hi. I'm just going around and asking what drew people to this panel. I'm sorry, not this panel, this particular workshop.
Like us without some.
Yeah. Yeah.
Okay. So my name is Wen Tan. I present graduates from Design for Social Innovation at School of Visual Arts. I was an interact with people. So I like when I was in my grad school, like I really very interested in the healthcare area, especially like using design, trying to tackle with some social problems, social issues, and this is like very close to what I'm interested in field. So
Perfect. Good. So you guys are all in the right place, I think. So I'll just go ahead and get started, and we can take people in as they come. So the way this is, I guess this was kind of branded as a case study. Now that everyone has given me a little bit of information about them, you guys won't be shy to chime in. Stop me if you guys have any questions, but also we're going to go through sort of a little kind of interactive brainstorming session together. So that will kind of be the first part of it, and then I'll circle back around and tell you guys a little bit more about Archive and what we do specifically. So we'll just do a full circle. But again, stop me if there's anything you have a question on. So My name is Sarah Ruel-Bergeron. Welcome to this particular session, Health Through Housing as a Proactive Approach to Humanitarian Efforts. I myself am a licensed architect. At Archive, we have a number of diverse people. So we do have MPHs, and we have people who are interested in public policy, and we have people who are interested in communications. And so we're a pretty diverse, small but very diverse group. Is this the one I do? Yeah, that works. Okay, so there are 7 billion people on this planet, all of which are entitled to basic human rights, one of which is adequate housing, yet 1.6 billion people around the world do not have adequate housing. So if we take a look at the Universal Declaration of Human Rights, Article 25, Section 1, everyone has a right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood in circumstances beyond his control. So what's really important about that particular sentence for me is that the first part of it is really linking health and housing. So health and housing are intrinsically intertwined in the way this is written. This is written in 1948, so this is an old document that we're all pretty familiar with, but this is the only place in the Declaration of Human Rights where health is mentioned, and more importantly, it's mentioned in tandem with housing. So we see that there really is a correlation between health and housing. It's just not something that's often focused on. So to get started, there's a few different ways that we can look at inadequate housing. It breaks down into so many different ways. One of the most, I think, visible ways, one of the things that brings us here to this particular day is humanitarian crises. We've been talking about refugees all day. And so just starting from that entry point, and then we'll move through others, but in the beginning of 2018, 68.5 million people were considered displaced. 40 million of them being internally displaced, and then 28.5 having fled their countries and are considered refugees or asylum seekers. So the way I wanted to start, this is an image from the Rohingya crisis that's happening in Bangladesh, and it is a coincidence that I'll finish the talk talking about Bangladesh, but what I wanted to do was to take a look at this image. It's a very obvious place for me to start to talk about how housing has an impact on health. So what I wanted us to do together, because we come from this environment, so I could tell you the things that I think are problematic, but what I'd like us to do is to really just think through how that is and just brainstorm through that together. So for the Rohingya crisis, it's happening in Cox's Bazar. They're kind of coming over from Myanmar. There are nearly 700,000 people who have come over in the past 9 months. Some of the immediate problems we're seeing from this image, for example, is that there's a very informal nature about how this housing has been built. It doesn't look like it's particularly coming from a certain agency. It's made up of found items and plastic tarp, and kind of wedged in wherever you could sort of carve out some land. We might be, I'm not sure if the blue things there are latrines. They might be. They're probably kind of where they've dug a hole and made a pit latrine there to accommodate. But this picture was clearly taken a few months ago. There is, in May 2018 actually, the monsoon season has now started full on. You have probably seen that there's actually even images of houses being completely taken out. Because there is no foundation to these homes. These are not structurally stable homes, and they're on kind of steep hillsides. So, and there is also one other thing I'll mention is that there seems to be some sort of water spout that is being provided there. You can see the sort of hill is a little bit wet down at the bottom, where that comes from. It's not clear if that's potable water, but either way you have some form of water source. So I wanted to ask if people can just shout out what they think would be a health hazard from this type of environment. How does this type of housing impact our health? water source, yeah. You had one here? Sanitation is definitely going to be a problem. And we know that open defecation is a problem, particularly in some cultures, but in low-income countries all over the world. So we can imagine what starts to happen when the monsoon season starts and all the rain starts coming down, and you had people kind of openly defecating in places that were possibly sort of higher ground. You have the latrines that are kind of probably filling up and dumping out. And so that kind of thing is really going to have an impact on homes that don't even have a door, right? What else do we think is one of the... Ventilation, absolutely. Anything else? Dust? Yeah. One more?
More informal, but like a sense of safety and security, since it's so informal.
Mm-hmm.
Roads or...
Well, and I think you're actually mentioning a number of things there. You're mentioning, no, that's okay. So you're mentioning infrastructure there. That's a really important part of it. You're mentioning security, infrastructure. I think you were also mentioning kind of like social services, like some sort of system, established system. So the informality of the camp versus a formality within a camp. So great, that's all really wonderful. So from those, let's just unpack those a little bit. So in terms of the sanitation issue, diarrheal disease is very common, and for children under 5 can cause anemia and reduce cognitive development. In 2016, worldwide, 1.6 million people died of diarrheal disease. Almost 500,000 of those were children under 5. One of the subsets of diarrheal disease, and we'll come back to this later, is cholera, which is transmitted by water that has been infected, often by fecal matter or persons infected, and is highly contagious, and if left untreated, people may die within hours of dehydration. So just being in close proximity with people who are already very vulnerable, we think that they're coming across the border, they're in a very vulnerable state, and then you're imposing these other very difficult housing conditions on them, it's going to exacerbate the problem. We mentioned lack of social services, including clinics, which can help often treat simple but deadly diseases, such as diarrheal disease. It doesn't have to be complicated to treat that, but when you don't have much, it might be complicated to rehydrate, make sure you're eating properly, get access to clean water so that the problem doesn't persist. Lack of roads and infrastructure can cause malnutrition and starvation from a lack of access to food and resources, including job opportunities, right? So if you're able to go out and sort of make a bit of money that you can buy some supplies with and you can bring them home, then you can be in a better condition. But, you know, you can imagine that these people probably have to walk down the hill to get to any semblance of a road, and it's very difficult to sort of trek out of these camps because there's no formal road system. What else did we mention here? We mentioned ventilation. So acute respiratory infections from lack of ventilation is a problem globally. 4.2 million acute lower respiratory infection deaths are estimated to occur among all age groups. Of these, 1.8 million are estimated to occur among children under 5. So again, these are all relatively visible things, but you can see that they have a really large impact on health. Whoops. So to give you a little bit of context about this slide, it's similar. It's also a refugee camp. It's in South Sudan from February. It's an image from February 2014. So this is the inside of a tent, clearly. It's a UN compound, which was estimated to house about 10,000 people due to fighting in South Sudan. So people were kind of mobilizing to this safe camp. So the person on the right is actually cooking something called cob. So there is a sort of open charcoal fire most likely happening, and she's cooking indoors. And then right outside they'll have a sort of nearby, they've mentioned that they have some sort of water source that they can bring water from. But what are some conditions that we saw before, or sorry, that we didn't mention before? What are some of the problems that we think might happen here as well? the last thing I'll mention is that the rains are coming. So there's a quote from these two women, and the rains are coming, and they're quite worried about the rains. Indoor pollution, yeah, absolutely. So I'll just run that to IIP. Anything else?
I would say
Yeah.
that maybe there might be some food contamination.
Mm-hmm.
We don't have chronic illness storage.
Yeah. We're gonna go into okay. And the other thing, one thing that I'm wondering is, how do we feel about the temperature? Do we think it's nicely climatized in these tents, or even in the Rohingya camps that we saw just in the slide before? Probably not, right? So extreme conditions. I'm sorry, I think you had something?
I was just going to ask, I'm not familiar with South Sudan. Do they have like dengue issues?
Yeah, absolutely. So not only will they probably already have kind of sort of mosquitoes lingering, there's probably dengue, yellow fever, and malaria that is prevalent in the area, but also a lot of these kind of, whatever the water system is, if it's pooling somewhere, you can see that they're collecting a lot of things naturally. I mean, they came with nothing, so they're going to collect all the things that they can find. So any place that's kind of left, that's a tiny little bowl, mosquitoes can breed in that. So absolutely, mosquitoes are a huge problem in these environments. And again, that's one of the other things that, you know, a simple clinic can help detect what's going on and provide some information about how to get treatment. But if you're nowhere near a clinic, you can die easily from malaria, dengue, or yellow fever. So anything else? That seems... Yeah. So these people are internally displaced, but absolutely, I think one thing that is not very discussed in a lot of, I mean, just because there's so many other larger concerns, but in inadequate housing in general, the state of mental health is a really important aspect of it, and the stress of being displaced. So mental health is absolutely one of those. Anything else? Okay, so tuberculosis is spread by people being in close proximity in non-well-ventilated environments. So this would probably be a prime place for tuberculosis to be spreading. Personal hygiene, although it's kind of a broader topic, but it can cause a number of problems. So food poisoning would be one of them, but pneumonia, skin infections, viral infections, hepatitis A, gastroenteritis, parasitic infections. I mean, there's a number of things that can be caused by problems with personal hygiene. And you know, if you're waiting for hours for a bucket just to be able to cook your meal, you're not going to take 3 extra buckets to be able to mind your personal hygiene. It's completely normal that in these kind of environments, that starts to suffer very quickly. And societal conditions are definitely, as you were mentioning, are definitely exacerbated in crisis situations. So mental health problems are increased from root shock as one of them, but also just living in inadequate housing, as well as sexual violence is a huge problem. And it all kind of sort of exacerbates one and the other. You mentioned the mosquitoes. We'll get back to the mosquitoes. The other thing that's been obvious and will continue to be obvious is, and I can't remember if we mentioned it, but dirt floors definitely cause diarrheal disease, and the case study will relate back to dirt floors later in the presentation, but from fecal matter being tracked in either from latrines and people just tracking it in on their feet. There's chickens, there's dogs, there's everyone kind of coming into the home. So that will definitely, if you're eating on the ground, if your children are crawling on the ground, it's just a way to increase the potential for infection, unfortunately. Was there anything else? Oh, the extreme climate conditions, just because I find this particularly interesting. It's not exactly something that will lead directly to a disease, but again, we have to consider who we're starting with. We're starting with an extremely vulnerable population. So we know that, for example, in the Syrian camps, I think it is in Iraq, some temperatures indoors are measured at 120 degrees. At the same time, you have even within the same Syrian refugee crisis in Greece, we can get down to 20 degrees at night. So you're getting below freezing. So we're having extreme temperature differentials, and it's very problematic in terms of weakening people who are already in a very vulnerable state. So speaking of the Syrian refugee crisis, we did take a look at some of the literature, so we were able to find some information about exactly what some of the main, I don't want to say complaints because they're totally reasonable concerns, but some of the things that are kind of repeatedly mentioned within the literature. So if we look at within the Syrian refugee, you're classifying people into 4 different categories. You have refugee camps, unofficial settlements, assimilated communities and regions, and then resettlements in Western nations. But you can see even within resettlements within Western nations, you have lack of heating within the buildings. You don't have AC, but you have damp environments. Damp environments are causing asthma. You may have overcrowding. So a lot of these issues are repeating across the board. However, when we do look at the proportion of issues for refugees, not surprisingly, the unofficial, if I touch it, it does something. I didn't realize that, sorry. The unofficial settlements, not surprisingly, are really the worst off, right? They're going to lack the social services on top of everything else. They're going to lack some sort of formal kind of donation of a tent, and so they're kind of finding the material to make their own home. They're not going to have a water spout. So just because it's unofficial and they're just kind of getting by as best as they can, it's not too surprising that that really is the condition where we see the most problems. And then at the bottom we can see the types and location of refugee housing in terms of how many people are in those. So for assimilated communities, we see that Turkey is really taking in a lot of people for the assimilated communities, whereas resettlement in Western communities, we know that that's happening mostly in the European Union. And you can see that refugee camps actually doesn't measure that highly, that there's a lot happening in terms of assimilated communities for the Syrian refugee crisis. This is not all refugees. So moving away from refugees, this is an extremely kind of common thing to see. This is still inadequate housing, and it is permanent. Some refugees are spending 50 years in camps. We've been talking about that all day, that there really is no such thing as temporary housing. But even when people are established and have been established there for generations, inadequate housing is still extremely prevalent. And so we're seeing that here, and there's going to be a lot of the same conditions that we found before. So food contamination, we're seeing potential for on the upper right, and there's some research going on about microfungus that is growing on poorly stored corn in Latin American countries, and some impact that can have on the gut biome, and potentially if that has something to do with stunted growth. And so that can, although it may not seem dramatic, it does actually have an impact on health, and it is a component of the built environment. A lot of people in low-income countries are sleeping with the grain next to the bed, and then there's pest infestations that are coming in. So that's one thing that we didn't talk about, but pest infestations, we did mention the mosquitoes, but all of those things are pretty related. Here we can see that obviously the walls are relatively porous, so the entry of mosquitoes will be extremely common. So screening could prevent that, but if you screen the windows, doors, and eaves, and you close it up entirely, then the lack of ventilation will cause people to simply sleep outside and not sleep under their bed nets, and then you're just defeating the purpose entirely. We can see a water spout, but we don't really know where that's coming from. There's also a large drum. They're probably piping the water into the drum on a regular basis. That's a perfect breeding ground for mosquitoes. So we see that there's a number of issues. The walls are also they can host insects, and there is the kissing bug in places like Bolivia, where you can be bit by a bug and then have a sudden heart attack, even decades after you've been bit, and it happens very randomly, but in certain communities this is extremely prevalent. So there's things like that that can be living in the walls. A lot of mosquitoes will rest in the walls as well, kind of in little nooks and crannies of the walls. So if you don't have smooth walls, that's a perfect place for them to be hiding. Make sure I'm not missing anything. All right, is there anything you guys think I'm missing? No, okay. So then, a little bit harder, but more local. We don't have to go that far to find inadequate housing and conditions that are problematic for health. So here we're clearly seeing a case of mold, pretty severe leaks and mold, which is causing asthma. Let's see. So mold and damp environments cause asthma, and for the United States, that cost can be upwards of $22.4 billion from 26. That's a statistic from 2016. So it's a significant impact. Pest problems are common. We saw them in other environments, but they'll cause salmonella, dysentery, gastroenteritis, hantavirus, all sorts of problems. Garbage accumulation can be a problem in lower income neighborhoods as well, and some of the conditions that we saw. The point is really to see that you don't have to necessarily be in a camp to be seeing some of the some similar conditions. So garbage accumulation can obviously lead to mosquitoes. Some of those mosquitoes, at least in the United States and in New York, can be carrying the West Nile virus. They won't be carrying malaria, but they can be carrying other things. And of course, things that we've been hearing about in the news, lead, asbestos, those are both causing a lot of health problems. So in 2014, for lead, 5,400 New York City children tested with an elevated blood level. And in 2017, 800 children had elevated blood levels of 10 micrograms per deciliter, which is much higher than the children from 2015. And in asbestos, for asbestos specifically, New York had 12,000 asbestos-related deaths very recently. So the asbestos is really just in so many different materials. And if you're in any of, it doesn't necessarily have to be public housing. There's a lot of old buildings here in New York City that have, if they're from the 50s and they haven't been repaired, you're probably being exposed to asbestos. And if it's cracking like that at the top, you're probably being exposed to asbestos. And when the paint is chipping and the paint has not been fixed or painted over in 20 years, you're probably being exposed. So there's a lot of different things that can be impacting us. What about a suburban house? There's problems in suburban houses too. I mean, we know that there's a massive obesity epidemic happening. So this kind of house, with a garage and a suburban environment, there's a lot of chronic diseases happening around what I would now consider pretty adequate housing. But it's just again to say that housing and health are so interlinked, and we've really been thinking about them as different things, and that we, as Archive, really believe that a paired approach and understanding them as intrinsically linked is really critical in being able to advance some of the really common public health problems and some of the preventable diseases happening in low and middle income countries. So just a couple of stats for the suburban house. The number of obese 5 to 19-year-olds rose more than tenfold globally, from 11 million in 1975 to 124 million in 2016. An additional 213 million were overweight in 2016. And then non-communicable diseases, meaning heart disease, stroke, cancer, diabetes, chronic lung disease, all things that we know can be helped with some physical activity, for example, are collectively responsible for almost 70% of all deaths worldwide. So it's not to say that you're in danger if you live in this kind of home, but you just have to be aware of how different components of the built environment can really have an impact on your health. So the other way I wanted to look at this, does anyone have any questions before I move on? No, we're okay? Okay. So the other way of looking at this is kind of from the opposite end. Are there some diseases that are being worsened by the built environment? Is there something that when we're talking about, global epidemics, are there things that we could have done better as professionals within the built environment to help or prevent some of the big problems globally? So we've been evaluating how the built environment can have a negative impact on health, but can the built environment also exacerbate a global problem? So quickly, endemic, and you all probably know this, but endemic is a disease that exists permanently in a particular region or population. So malaria is one of these and is kind of a constant worry. An epidemic would be an outbreak of a disease that attacks many people at about the same time and may spread through one or several communities. So Ebola would be one of those. And a pandemic is when an epidemic spreads throughout the world. So something like HIV and AIDS. So if we think about when we think about health and humanitarian crises, we think about epidemics and the types of things like Ebola. And so that's why I wanted to bring them back in. But you'll see that once I've sort of given a bit of a description, there's ways that we can talk about it in relationship to the built environment, and that's what I want to kind of bring forward. So Ebola spread throughout the world as an epidemic as recently as 2014 through 2016, but as recently as June 10th of this year, 55 cases were found in the Democratic Republic of Congo. So that's what, 10 days ago? So it might be flaring back up. To date, a total of about 31,000 Ebola cases have been reported, with almost 13,000 deaths. It's a rare and deadly disease in people and non-human primates, and the virus is primarily located in sub-Saharan Africa. Again, we know a lot of these things. Scientists, but what's important a lot of times in these things that we're going to talk about is actually the exact mode of transmission, and can we have some sort of impact on the mode of transmission. So scientists think that people are initially infected with Ebola virus through contact with an infected animal, such as a fruit bat or a non-human primate. And then from there, the virus spreads from person to person, potentially affecting a large number of people. It can spread from person to person through direct contact with blood or bodily fluid of a person who's sick or who has died of Ebola. So someone who has died of Ebola can still transmit Ebola for up to a week, and the virus can still be detected within the body as long as 10 weeks after death. So that has, I was particularly interested in the Ebola case, so I knew that there was a problem with people who have passed, dead bodies. But I find that particularly interesting. It's a very different, it's very different than how we've had to look at other kind of epidemics, and has a big impact on kind of cultural and behavioral kind of practices, I guess. And I think it's very difficult to have a conversation with someone about their cultural practices in terms of death. So, and a lot of people were hiding their dead bodies. And so, anyway, so in terms of built environment interventions, full quarantine, which is kind of what we're seeing here. So these people are within a kind of compound that's fully segregated from the rest of society. These are people who are unfortunately infected with Ebola, and whoever is coming in to provide care is wearing full personal protective equipment. Proper, as we mentioned, proper disposal of dead bodies and funerary practices. My understanding is that some people bathe and kiss the body after they've passed, and so things like that. Just the education component is incredibly important for that. And then in high-income countries, so I was working at the time when Ebola came through, I was working on emergency departments at a healthcare firm, and so we quickly had to scramble. We were well along on a plan to massively expand an emergency department on Long Island. And when Ebola came through, there was a real rush to do isolation units that would be capable of withstanding like what I guess we would think right now as one of the more extreme epidemic type of things to deal with. And so for that, there is a real impact on the built environment, because you have to design a room that has negative pressure, so it's constantly drawing out air so that no air can seep back into the hospital. So instead of fully sealing it, it's just about drawing the air out continuously. You have to have tanks underground that will receive all of the waste coming out of that room, and that waste needs to be, it's not going into the sewer system, it's going into a tank that is kind of individually pumped and taken care of as a really kind of medical waste, toxic medical waste. And then you also have a dedicated ante-room, so someone will enter the room, the patient is beyond the door, that's where you put on your full protective equipment, and then you can enter the room. So there's a real, in terms of spatial arrangements, there's a real dance to do with designing for this type of space. So interestingly, for malaria, dengue, and yellow fever, the reason I'm putting these together, so malaria is, you know, an epidemic. It's massive. It's in 91 countries, and in 2016, an estimated 216 million cases of malaria were detected, 90% of them being in Africa, and 91% of malaria deaths being in Africa. Malaria, well, all three of these diseases, all three parasites are spread from person to person, but through an infected mosquito. So a mosquito will bite me. There's a time when that virus needs to sort of develop within the body of the mosquito, and then when they go feed from you, then that's when the parasite is transmitted. So the fact that that's the sort of path of transmission is what's crucial here. And person to person, malaria, dengue, and yellow fever cannot be transmitted. Dengue fever is also massive. It's endemic in more than 100 countries. As many as 400 million people are infected yearly with it. And for yellow fever, 47 countries in Africa, Central and South America are either endemic for or have regions that are endemic for yellow fever. A modeling study based on African data showed that in 2013, the rates of yellow fever were from 84,000 to 170,000, which I think is a pretty big range, but I guess this is modeling. And that the severe cases were 29,000, or sorry, the severe cases that led to death were 29,000 to 60,000 cases. Yeah. I think it is also a vector transmitted disease, meaning that the mosquito is necessary. No, it's not, because you can transmit it from body to body, because you're transmitting it to your placenta. So no, it does not fall within this category. But what is important about these that we have looked at, because we've dealt with malaria, kind of malaria-proofing houses, is that these are, I mean, there's hundreds of species of mosquitoes, and these, they bite at different times. So based on when they bite, malaria is transmitted by, I think it is the Anopheles mosquito, whereas dengue is Aedes aegypti. I think there might be some cases of malaria that are transmitted by Aedes, but for the most part, malaria is with Anopheles, dengue is with Aedes aegypti, and yellow fever is Aedes aegypti and a different one. The point being that depending on when they bite, meaning if they bite from dusk until dawn, you have the potential to impact through the built environment the rate at which people are getting bit, because they're indoors, they're sleeping indoors, and so you can have an impact there. If it is like dengue, where it is with Aedes aegypti, who is biting during the day, there's not much we can do about that. People are active, they're out, they're moving, they're working, whatever it is they're doing, they've got their doors open, they're not necessarily indoors. Perhaps the children are, but typically you're moving in and out of your house. So that's really important for us, because we can have impact on some diseases and not on some other diseases. And cholera, really a number of fun topics. So an estimated 2.9 million cases and 95,000 deaths occur each year around the world from cholera. Without treatment, death can occur within hours because of dehydration. Cholera infections are most commonly acquired from drinking water. Oh, sorry, I forgot about the built interventions. Let me go back one slide. In terms of built interventions for malaria, dengue, and yellow fever, I led up to us impacting it through the built environment and then didn't give you the secrets. So for built environment interventions, so you can see here that you have nets, but you can also kind of mosquito-proof the house by not only patching the holes in the walls and really kind of sealing it up, but also by providing screening for your windows, doors, and eaves. There's a few other experimental tests for the eaves. There's things like eaves tubes. There's people who are trying to raise the home above where the mosquito kind of flies, and so if they kind of give up, they'll just fly through. So the way that mosquitoes typically go after you is, let's say they fly low at the ground, and then once they hit the house, or once they hit something, they're following a plume of your body odor. So that's seeping out of the house. So they'll fly towards that plume, but low. Once they hit the house, they'll start going up the wall until they find an opening. So, and they're very persistent. So that's why the eaves, they'll keep going until they get to the top of the house. So those eaves, it's important to make sure that those are enclosed as well. There's also very commonly indoor residual spraying. That's not something that we've worked with, but you kind of spray the inside of the house. That lasts about 9 months typically. And that's it. So that's it for interventions that you can do to the built-in. Well, I wouldn't say that's it. I'm sure there are other innovative ways to affect this. I have heard that there are people looking into the climate within the homes. So for the mosquitoes who are biting, they usually bite. They'll kind of feed on a human, and then they'll go sit on a wall and kind of process their meal. And they're feeding to be able to lay eggs. Because, the two of the mosquito types that we talked about, it's only the female mosquito that bites. So they'll sit and they'll kind of process their meal. And during that time, so if you're biting at, midnight, then you're kind of processing your meal. The temperature is going to rise in the house, and there may be a point where it's so hot in the house that it actually might kill the virus within the body of the mosquito. So that's kind of new research that I find really fascinating. And I don't know where it's going to go yet, but that kind of idea, you don't want it to be too hot in the house, but there's a difference between if you have open eaves, metal roofs. So in some cases, the metal roofs, even if it's hotter indoors, is a more effective malaria prevention strategy because the temperature inside the house is rising to a certain level at a certain time. Back to cholera. So I mentioned already 2.9 million cases per year, 95,000 deaths occur 2.9 million cases, 95,000 deaths. Cholera infections are most commonly acquired from drinking water that already has the bacteria within it or into which it has been introduced from the feces of an infected person. Direct transmission from person to person, even to healthcare workers during epidemics, has been reported, but is not very common. So it's really not a person to person. It's really that relationship with, unfortunately, the fecal matter of someone who's been infected. So that gets back to our first image of the Rohingya crisis, where you see that based on the way that that town has been planned, based on the fact that there's no doors, based on the fact that if those are latrines, they're completely set up on the hill. If someone comes into that camp with cholera, and I think we've seen in past cases that an aid worker can even bring that, that can be exacerbated really quickly just because of the conditions that they're living in. So what can we do about cholera? Obviously, proper sanitation facilities are required, potable water for drinking, cooking, hand washing, and cleaning, right? We need it for the whole cycle of hygiene, not just for drinking, and flooring interventions. So that's where Archive comes in. One of our biggest projects at the moment is a flooring intervention to combat diarrheal disease, but also obviously in an effort to combat ultimately cholera. So we wanted to present this case study just so that we can really kind of drive home the point that we've been talking about. And we're really hoping to, through our intervention, make this vulnerable community more resilient by increasing knowledge and providing a cleanable, long-lasting floor decreasing diarrheal disease, and ultimately the fragility of the community to a cholera outbreak or other crises. So I'll get into more detail about the case study in Bangladesh. We're doing this in Shavara, which is 20 kilometers west of Dhaka. 70% of people in Bangladesh live on dirt floors, and from the stats here on the right, I think that's too small for you guys to see, but we know from a project that was done in Mexico called Piso Firme, that when you create concrete floors and replace dirt floors with concrete, diarrheal disease can go down by 49%, parasitic infections can go down by 78%, and anemia can be decreased by 81%. Cognitive development in children, with children who are under 5, can be of 36 to 96%. So you can really have massive impact. So we're looking into replicating that, I guess is how I should put that. So if we look at the disaster cycle, I mean, how does this come back around to what we're talking about here today in humanitarian crises? So if we look at a disaster cycle, what we've been talking today mostly about is kind of the event, the response, and maybe some of the preparation. So where we see our work is in the mitigation category. So we're really preparing communities, making them more resilient so that in the unfortunate event that it does come around to the event, that the communities will be stronger. So Archive's mission is that we're operating in the spaces of development, health, and architecture by prioritizing housing design as a key strategy in combating disease around the world. So we've been talking about that this whole time, but just to drive that home. We work specifically in existing housing stock. So we don't work in refugee camps. We really believe in people owning their homes, just because then if you come in and you do a $500 intervention, it doesn't make sense if somebody might be displaced soon, or as soon as you improve the home, someone else is interested in that home. So we want to make sure that the people that we're working for have some ownership of that home. So because we're working on existing housing stock and we're not building new, and we're trying to build at the most cost-effective way possible, what we want to be doing is targeting very specific items of the built environment that we can have an impact on, and then we look at kind of a matrix of how that might impact particular diseases. So for example, for asthma, oops, oh yeah, right, I forgot I can't touch this. So for asthma, maybe if I do that. For asthma, if you can improve the wall material quality and avoid, mold and dampness, that should prevent asthma, but you also need to have ventilation because mold will grow if you don't have ventilation. So it's just understanding, this is not to say that we have 5 products that we deploy. We're just saying that using these as some of the key components that we can impact to then have a positive impact on health outcomes. That's what we're trying to get at with this chart. In terms of our process, there's a few different ways that we can work. So we sometimes develop and implement our own projects, and that's what we'll see in Bangladesh. But we've also often worked as technical assistants, and we are doing that on some projects now, for governments, organizations like the Clinton Health Access Initiative, other partners, to provide expertise on how the intersection between health and housing really happens, and ensuring that the intervention is site and culturally appropriate, and that the education is relevant to that community, and that the health metrics are evaluated in a rigorous and scientific way. So there's amazing organizations doing housing. There's amazing organizations doing public health interventions. What we're saying is that we really need to be measuring where that comes together so that we can use them as a paired approach rather than seeing them as independent of each other. So for example, Habitat for Humanity is probably having amazing impacts on health, but I don't think they're measuring that. That just has not been one of their priorities, because measuring in a scientifically rigorous way is, as the MPHs or whoever will know, it's a pretty large project in itself. You can do just research on its own. So we're really trying to pair those two approaches to understand, and that has there's a large education component that we'll talk about. And so the idea with our process diagram is that we start by investigating a problem, which you'll see a map of how we do that in a minute. we fund a project, we'll design it, we do some education in country, we implement it, we monitor and evaluate and report, so we're doing external advocacy, and then the cycle starts all over for us. So we are really trying to scale up our projects. We don't think that just doing a handful of homes in one community is going to make the difference. We really want to be trying to scale up our projects, but of course that's dependent on funding, so you have to do it in phases. So where do we work, and who are we? We work all over the place. And what's important about this map for us is that we, like the New York City, when we brought up the New York City apartment, we don't think that vulnerable communities only exist in low and middle income countries. They exist everywhere. And so one of the projects that I really like, it was mostly an advocacy project, but was in London. There's high rates of tuberculosis in a couple of boroughs in London because of the immigrant population that's bringing it. And we were able to do, there were two different campaigns, but one of them was to just go in schools and do an education campaign with the kids and teach them, these are red flags of the environment. Like, if you see this in your home or in your neighbor's home or in your friend's home, you should tell somebody about it because that's dangerous. So that's overcrowding, that's lack of ventilation, that's no sanitation facilities, that's mold, moldy environments. It's also symptoms of the persons themselves. Are they coughing? Are they, so giving them kind of toolkit of what they need to know and then how long the treatment is. So treatment for tuberculosis is 6 months, and if you break that, then you're dealing with the antibiotic resistant, but yeah, you're dealing with resistance. So you really have to make sure that you do the full cycle. So giving those tools to sort of middle school kids, then they can bring it out into their communities and really talk to their families about what some of those problems are, or just be kind of little cops for it. And we know that 3 years after we did, was again just an advocacy campaign. We didn't do any built environment intervention there, but we know that 3 years after, there was a decrease of tuberculosis reported to the Department of Health Services by 20%, I think. So we did see, I wouldn't say it's necessarily only an impact that we had, but it contributes to the knowledge within the community. And once you have the knowledge, that empowers you to do something positive about it. So why do we work where we work? We focus on the stats. So we start with the statistics and the data of what's happening where. Usually it's where are the statistics the worst, where are we seeing conditions that are really bad, and we focus on that, and we're targeting a particular health outcome that we think we can have an impact on from the built environment, except for these two cases, so Namibia and Swaziland. What's interesting with both of those is that the governments are attempting to eradicate malaria by 2020. They're very close. Their malaria rates are below 1%. But that means that they've tried all of the tools they had, so they need new tools within their kind of Rolodex of tools to really get to the eradication point. So the government approached us about giving them some additional tools and training to be able to do that. So I mentioned the Bangladesh project. I will come back now to the Bangladesh project and just talk about it. Oh no, I ran out of time. Do you guys want to hear about it? If I go really fast? Are you guys okay with it? Okay, sorry. So we started working in Bangladesh as a reaction to the fact of the statistics I gave before, that 70% of the population lives on dirt floors, and that we knew the kind of impact that we could potentially have, so 70% decrease in parasitic infections, for example. And so we linked up with a local implementing partner named ADESH. They have been in their community for 30 years. They've been doing women's empowerment. They've been doing vaccination campaigns. They've been doing water and sanitation projects, and so they know their community in and out. And so that's a perfect local implementing partner for us. And they knew that there was a real need for this particular change. Not only, what we like to think about for our projects is, absolutely we have an impact on diarrheal disease in this community through this intervention. But we also have, as you can see in the image on the left, that house is now much more resilient. And Bangladesh is a country of 700 rivers. It floods continuously. There are monsoons, as we're seeing in the Rohingya crisis. So flooding is extremely common. Before that, what we have is this kind of thing, which is a dirt plinth. When it rains off the roof, it falls here and it erodes that ground. When the waters come through the town, that also erodes the ground. It's also that mice and other things will come up from underneath. And absolutely, the child under 5 is spending their life on the ground. And actually in Bangladesh, it's not only the child under 5. People are eating, they're resting, they're socializing on a mat on the ground. And so it's a very, I guess, dangerous place, you could say. So this is a typical existing condition. I don't think there were any architects here, right? So I'll maybe just skip through them. Because I can go into more detail, but I guess I'll keep going in the interest of time. And this is also an architectural kind of drawing, but just to say that the top portion, so really from this image, everything that's not dirt is going to stay, and it has to stay there through construction. So because we work on the built environment and because we work with a really tight budget, what we're going to do is excavate around that column and dig out the bottom and then do a floor that way. Oh, I think I'm going to tell me I have to stop. Huh?
Sorry, the closing is going to start in a bit. So
Okay. Yes, I'm shutting it down, I promise. Okay. So anyway, just to say that, it's not just pouring concrete. I mean, there is a floor assembly that has to happen there, but the top portion is going to remain consistent. And so I mentioned the education component. It's incredibly important for us. In some cases, it is the whole project for us. But we really believe that it's a key to a long-lasting project is to have awareness and understanding not only of the treatment options, but preventative measures that include the built environment and best practices for sanitation and hygiene, just kind of reminding people what they can do, even if they're not receiving a floor. So we do the education component with community members, of course with the beneficiary members, but also with community members. We've produced a video, which I thought about bringing, but clearly I'm out of time. It's a 2-minute video, but that we're going to put out on national television in Bangladesh that is just going to reinforce that message, that housing has an impact on health. And the idea is really to also bring this to, we had 2 kind of key stakeholder roundtable meetings where we're really attempting to bring this up with government officials and say this is a really positive way to have an impact on public health and also have some of the additional benefits of stabilizing the home through a floor that is very long-lasting and resilient. It's also increasing the economic capacity of that family. They can go out and look for credit now because their home is more stable. So there's other kind of secondary benefits that come along. So it's not just a public health intervention. There are other benefits that come with this. And we know, so I went and visited in, I haven't even told you guys how many floors we did. I visited in October. We had completed 10 houses in 2014. We completed 57 more homes this March, and we're doing 150 additional homes this fall in the hopes that we can roll out a microfinancing version of this project beyond that, so that the local implementing partner can really handle the project there and can just, whoever needs it, they don't have to be part of the selection criteria. So our selection criteria includes a child under 5 because we're measuring the health outcomes, has to have a mother at home, and so people who are not able to fit into the framework of the project can get their own floors. So that's something that we're working on, but just the really quick numbers. So the 67 floors is adding up to 226 beneficiaries, 69 of them being children under 5. Nearly 1,200 community members were trained, and we intend to reach 535,000 people through the public media campaign that we're doing about the importance of housing and health. I've mentioned a couple of times the scientific study that we've done with these floors. So we had Brack University working with us. They're a leader in diarrheal disease, and they're based in Bangladesh. So they went out and took swabs of the dirt floor before we did the intervention for control group and for study group. So we had 57 control houses, 57 study houses, and we're going to do it again this month. So we'll have our final report in September. If you guys are interested in the results, I can give you my email. But we know from the initial results that 80% of the homes had infestations of both Ascaris and E. coli. And Brack University was really surprised by those findings. They knew that there would be infestation. They did not realize it would be that high. So that really means that we are able to have a big impact. I'm done. So in conclusion, we're interested in presenting this case study to you guys because we firmly believe in being a part of the disaster mitigation cycle and helping to create more resilient communities that are better prepared to confront crises. So as you've seen, our projects take multiple forms. So sometimes we do malaria, sometimes we do this. We're working on acute respiratory infections, but using innovative design interventions to improve health outcomes in vulnerable communities worldwide remains in line with our mission. That's it. Phew, that was like a race. I had a lot to cover.